of research that we did using narrative analysis. But in the course of doing that, I'm going to introduce a lot of the concepts that we'll be going into more depth with in the workshop. So it's a bit of an introduction. Several people kind of stopped me before the talk and said, are you going to tell us how to do narrative analysis? And so I know a lot of people are interested in that, but there isn't really a manual of how to. And I really see narrative analysis as a branch of qualitative analysis in general. And at least in my humble opinion, in my mind, there isn't a correct way of doing qualitative analysis, and certainly not for narrative analysis. I think there are things that we maybe look for in common, and I'll mention some of those, but how people go about it is very creative and artistic in a way, and individualized. So just a word for the workshop, we'll be looking at a lot of different exemplars of how different people have done their narrative analysis, but there isn't a way. So I'll talk about, one thing that I did here. Let me see if I can get this going.
The other way around.
Oh, okay. Thank you. I put this slide in because before going any further, I wanted to make sure that I gave proper credit to my colleague, collaborator with whom I did this particular kind of research, and that's Dr. Paul Haydet. Paul and I worked together on a big NIH federal grant while he was at Baylor College of Medicine in Houston, and Rick Street and I joined that grant. He's now at Penn State College of Medicine. Paul is a physician who thinks he's very multi-methodological, but he thinks narratively, and we'll be reading one of his pieces during the workshop as well. But what I'm going to present today was done both by me and by him. There's three kinds of main questions that I'm going to be approaching with the talk today by looking at a particular story that comes out of a bigger research piece, and I'll explain that in a minute. The first question, what does it mean to be an active and engaged and participatory patient? And that really was the research question that launched the study that was undergirding the study that Paul and I did. So that question was there from the very beginning, and it's one that I remain interested in. Like, how do we have a say in our own health status and our own health care? Second question, how does collaborative patient-provider communication occur? That wasn't necessarily there in the beginning of our research study, although I think both Paul and I are advocates of patient-provider collaborative communication. But the particular case that I'm going to talk about today is very illustrative of that, and we learned a lot from that case about that subject. And then the third question, in light of just what does it mean to do narrative inquiry, is in what ways does employing a narrative perspective help to clarify the above questions? Like, why was this a good approach to take with what we wanted to learn? So I'll try and address those three things. So I know not everybody here is I know your research isn't necessarily connected to health for some of you, and So what I'm talking about today may not be of central interest to you, but everybody sooner or later becomes involved in the healthcare system, if not as a provider or a researcher, as a patient, okay? If you live your whole life without doing that, then you're a very lucky person. But for most of us, we do encounter the healthcare system. So I thought that was kind of the common denominator, no matter what kind of research you do. So I'd like you just to take a minute to kind of fix in your head and think back to the last, not going in and getting vaccinated or something, although that, I guess that could be it, but your last significant visit where you actually had to talk with your healthcare provider and to think about these things. If you felt free to talk about what was really on your mind, what your concerns were in coming in. Did you broach things first, or did the provider take charge of that session? Who spoke more during that meeting? If it was something you were really concerned about, did you plan in advance what you hoped to cover during that meeting? Some people even write their questions down, because sometimes when we get in there to see a physician or another provider, we feel kind of pressured or nervous or aware of time limits, and we may not get to say everything we want to say. So sometimes writing things down ahead of time might be helpful. And if you did write things down, was that followed through on? Did it occur the way you planned it? Did the provider really listen to you? Did you feel heard when you left there? Were there still unvoiced or unresolved issues on your way out? So those are all things that I think sooner or later happen with all of us. And I just want to add a footnote here. I've very consciously used the word provider because we're going to be looking specifically at a patient-physician interaction as I talk. And that's probably what I know best, because as Mohan mentioned, I worked in a medical school for 20 years, so I came mostly in contact with doctors, but I also worked with the whole panoply of providers, with dentists, pharmacists, occupational therapists, nurses. I was in a large medical center where all those schools were represented. So I believe what I am going to say, even though it's about a doctor-patient interaction, is pretty generalizable to other kinds of health providers. So this question of being an active patient has been around for a while, and I'm just touching on a couple, what were for me key pieces of literature that helped to shape conceptualization of what does it mean to be an active participatory patient. And that research is going on until today. So I didn't do all the most recent because I was just trying to pick up on some things that were foundational for me. So actually, prior to even the first one that I have there were two psychiatrists, Saj and Hollander, who put out a model of physician-patient communication that is actually very similar to what I'm going to talk about with Deborah Roeder's model. But that was as early as the 70s, Saj and Hollander. No, maybe even the late 1960s. And they brought up the notion of a consultative, I think that was their word, a consultative relationship between a doctor and a patient, rather than the traditional medical model, which is doctor dominant, active, patient passive, do what the doctor says. so it even came up earlier than this, but in a piece that got a lot of attention in the New England Journal of Medicine, Timothy Quill, who was a physician back in 1983, introduced the notion of a partnership between patients and physicians, and even the notion of a contract between them, not the kind of legal contract that you sign, but an implicit contract of what would shape this partnership. Mohan's introduction about how far back I go in health comes, I guess that just means I'm ancient, and so I have an ancient publication there, but in a book I wrote early on about doctor-patient communication, I also talked about patients and their providers having reciprocal and necessary knowledge, and what was kind of new about that was nobody was crediting patients as having knowledge about themselves. It was like, you go to the doctor because that person has the important knowledge. But unless patients can come in with information about themselves, real problem solving and decision and informed decision making really doesn't take place. Deborah Roeder and Judith Hall created this model in the early 90s, their power and control model, in which they had kind of a matrix with 4 squares in it. The default matrix is where doctors and patients both feel powerless. And I think that happens more often, at least I'm talking out of a U.S. context here, and I hope during my 3 weeks here I'll get more information about a Singaporean medical context. But I think as the U.S. has moved into managed care, and right now I think healthcare is up for grabs in the U.S. The shutdown of the U.S. government has a lot to do with resistance to a healthcare plan that President Obama is trying to institute. So it's being referred to mostly disparagingly, I think, as Obamacare. But I think both patients and doctors at times do feel kind of powerless because the bigger structural forces have taken over, and both the amount of control and choices that either the provider or the patient have sometimes seem very constrained. So that's one quadrant of their model. Consumerism is where the patient is feeling pretty fully in control, and the doctors or other providers are working for them. I don't know how often that happens. I do think being able to increase one's own knowledge of both disease options, health options, and other kinds of things, clinical trials, things like that, have helped patients to feel more powerful in their encounters with healthcare professionals, because what used to be very mysterious information is now more available. Paternalism is what I was talking about before, with the doctor dominance, patient in a very weak one-down position, and then mutuality, where there's a greater evening out of control. And I think social scientists who work in this area, communication people, Deborah Roeder, I think, comes from a sociology background. I think the social science people that interface with medicine have leaned toward this notion of mutuality and evening out of power. That seems more egalitarian, seems more fair. It seems like yes, we're both contributing to this interaction, but I will say, and I lean toward that too, but there are certain people that really don't want that, and that's their right. They want the doctor to be fully in charge. Or they want themselves to be fully in charge. My colleague from Texas A&M, Rick Street, who's devoted a lifetime to studying physician-patient communication, developed from one of his studies, or from several of his studies, this finding that there are 4 verbal features of patient participation, and he defined those as question asking, being able to express your concerns during a medical encounter, being able to assertively state your own opinion, not feeling cowed in doing that, and then being able to share one's health narrative. And it takes a fairly assertive patient to be able to do all those things, because we have a whole bunch of research that preceded this that said that patients were cut off very early. By very early, I'm saying 18 seconds into their first statement when they get into a medical consultation, and they get derailed from doing that. We had a big push to do patient training. I mean, usually we don't get trained to be patients, we just show up. Doctors get trained in communication, but as patients, we don't get trained. So there was a big push just to train people to be able to ask questions during a consultation. Because a lot of people, like I said before, if you don't write it down, you forget the question, or you feel this is a dumb question, I don't know if I should bring this up, I don't know if I should take the provider's time in doing that. And then this was, at least in my mind, a kind of a landmark study, the last one by Greenfield, Kaplan, and Ware, where they showed a correlation between patients asking questions and actual health outcomes. And since that particular study, there's been a whole slew of these kind of outcome studies that show when patients are actively engaged in communication with their providers, really good things happen. They recuperate from surgery earlier. They get out of the hospital earlier. They do better with medications. There's just a whole range of health outcomes now that have been documented by patients who are more active in their own care. So that was the background we were coming from. I'm going to just quickly go through some, as narrative scholars, and I'll count Paul in that, some assumptions we came into this study with, and these are things we will talk about more in the workshop, that health, it really, it should be health/illness narratives. The term illness narratives actually has been around probably longer, but I wanted to make it inclusive. So we're talking about stories that people tell about their own health status, and an illness narrative kind of connotes that we're talking about being sick, having a disease, and that kind of thing, and that is, those certainly do exist, and we're going to look at one. But I think also your own story about keeping yourself healthy, about preventing disease, those are health narratives as well. So health or illness narratives function in five different ways to make a disorderly world more coherent. Is one function it serves to kind of organize yourself in the form of a story, to justify decisions, chosen ideas, and actions that we take. Our stories kind of bolster that. Just asserting control in your own world, and this is I think these narrative assumptions exist in all kinds of narratives, not just health narratives. But the asserting control is really important when you are sick and all of a sudden your world becomes very chaotic and it seems outside your control. So having a story that helps you regain some of that control is helpful. Transforming identity, and again, if you have experienced a serious illness, or if you've taken a turn in your life to make yourself healthier, there is a change in identity as you change your health status. And finally, forming community, because when your story meshes with other stories that other people have, there begins to become a community of interest that also helps people feel stronger and better. Health or illness stories, and maybe this seems obvious, but maybe not, are not exact recountings of real-time events. And this is kind of interesting because doctors sometimes, in kind of a derogatory way, and I've seen this in patient charts. I don't know about in Singapore, but in the US, patients aren't privy to their own charts and what's written about them. So a common phrase that you'll see in a patient chart is, patient is not a good historian, which means when the doctor sits down to do a medical history with the patient, they're not telling things in a sequence and in a way that the doctor wants them to. There's a certain kind of form that doctors are trained to get. So patients are labeled as not being good historians. That would be a more exact recounting of things in a real-time sequence, at least the sequence that the doctor wants. But rather, people's stories are created in ways that advance their particular purpose for the particular people that they're talking to. So there is a creative, dynamic, inherent flow in stories that help us to do that. So narratives are different than chronicles. A chronicle would be a series of events, as they occur, usually in some temporal order, but that's not necessarily the way people tell their stories. And finally, and I hope you'll see this in what I'm going to talk about, humans are both storytelling and story-living beings. So as we tell our stories, we are simultaneously living them, and our stories change in the process. So I used this word emplotment in the title, and I wasn't trying to be, overly academic and use mystifying language. So let me step back and try and define that. My colleague, fellow narrative scholar, Lynn Harder, and we'll be reading some of Lynn's work in the workshop next week, defines emplotment as how characters and actions organize in time to enact a movement toward resolving a problem. And I would say that that's kind of the definition of a plot. Okay, a story plot occurs when there is a really big tension between some forces going on. Or in Jerome Bruner, the famous psychologist, in Bruner's words, there's a rupture. Something happens in the course of our lives that really throws us for a loop. And Cheryl Mattingly, who is another wonderful narrative scholar who comes out of anthropology, but also Cheryl was an occupational therapist. So a lot of her narrative work was informed by what she saw as a therapist. She defines emplotment, or she associates with it, trying to figure out what story am I in when something has happened in my life that has really thrown me for a loop. So in her experience as an OT, an occupational therapist, she saw a lot of people in the area that she worked in the hospital come in from either wars or from accidents in which they suddenly become paralyzed. They become quadriplegics or paraplegics. And of course, their whole life story changes at that point, and they're really thrown for a loop and have to figure out what story am I in. That's kind of a drastic example. Many of us might have had something happen to us that's not quite that drastic, but still kind of makes us stop and say, how has my story changed, and where is it leading me now? We won't be reading Matting, although we could have during the workshop, but we are going to be talking about that life rupture that happens with paralysis. So the story I'm going to tell, but I'm going to try and use as many of her words as I can fit in here, is Gina's story. So this is one of 16 in-depth interviews that were part of the study that Paul and I conducted. We didn't conduct all the interviews. He did some because they were done in Houston, and I don't live in Houston then, and some other people did some of the interviews as well. Now, for those of you who are not qualitative scholars, you're thinking 16 interviews sounds like a pretty paltry amount of data. But I would say it's different with qualitative work. So we're not trying to generalize to a whole population, but we are trying to see patterns that recur and figure out what those patterns mean. So within those 16 in-depth interviews, there were 6 that really stood out to us. And again, remember our question was, what makes for, or what's the meaning of being an active patient? So that's what was driving this. And there were 6 that stood out because they were so different in how people enacted or didn't enact activity as a patient. So for those 6 that we started with and we really focused on, there were over 20 iterations of, and there were 3 of us reading these 16 transcripts, 20 iterations of individual reading, notation, and I'm not going to say coding. It was notation because we weren't trying to code. The question came up earlier, what's the difference between what you're doing and grounded theory? And in grounded theory, we would code. I guess in a way we were coding, but we were looking for more narrative kind of categories. So we were looking at what are the plots that seem implicit in the stories that these people are telling us, and who are the main characters? Are there heroes or villains or innocent bystanders, or what is the time sequence that tends to get emphasized? Are people kind of mired in the past or looking back to the past? Are they really kind of very present oriented, or are they oriented to the future? So we were looking for things like that. So it turned out over 40 hours of work was involved with analyzing those 6 examples, and then another 10 hours on the remaining 10 transcripts, because after those 6, we got a framework that we thought was working pretty well, and we wanted to see how the remainder fit into those. And I'll get to that framework here, but we're going to do it by going through a story first. This particular population of people were recruited from 2 different healthcare locations, a private clinic and a veterans clinic. And the questions we asked them were about what's it like to live with a chronic illness. So everybody that participated in this had some kind of diagnosis of a chronic illness. And our questions were loosely based on Arthur Kleinman's work. And for people doing narrative and health, Arthur Kleinman is a pretty seminal figure. He's a psychiatrist who is also trained in anthropology. And in fact, he did a lot of his anthropological work in China with Chinese population. And so he developed a method for teaching his medical students, and what he says is, so he wrote this book in 1988 called The Illness Narratives, and I would recommend it to people wanting to do narrative work, particularly in a health context, because it's a great book. And he called what he did with patients a mini ethnography, and he was training his medical students to do mini ethnographies. And he had 8 questions that he kind of narrowed it down to teach the medical students how to really get from the patients their illness narratives. And it was things like, what do you think caused this disease? Not what did the doctor tell you, what do you think? How is it affecting your life? How do you think it should be treated? You may or may not agree with your doctor, but what do you think would work? Because a lot of times people are doing things to treat their illnesses that they wouldn't even mention to their doctors, but they think would work. Who's in control of the situation now that you have this chronic disease and so forth. So that's how our interviews were organized. So out of these 16, I picked the story of Gina, and the reason I did was we really liked Gina's story. I think we spent more time with it than almost any of the other ones because it taught us a lot. And it really taught us a lot about this collaborative relationship between patient and doctor. Not everybody went that route. Gina went that route, so we didn't start out to learn about that, but she taught us a lot about that. And also, I picked that story because it's kind of a happy story. A lot of times, people hear you do health communication, they'll start in with the really problematic stuff. Oh, you should hear what happened with this doctor and me and how poorly I was treated in the healthcare system. And the whole time I worked at the medical school and people knew that I was teaching doctors communication skills, people would tell me those stories all the time about all the bad stuff that happened with them. But this is kind of a more positive story, so you don't hear I think they happen, but you don't hear about them as often. So, okay, Gina is a 34-year-old woman from the state of Louisiana in the U.S., diagnosed with diabetes at age 25, and I want to say a couple things about that first line. So, first of all, diabetes, I did a really quick Google before I came here. There is said to be a diabetic epidemic occurring in the U.S. and has been for probably the last 10 years. At present, according to the current U.S. statistics, there's 25.8 million children and adults. That comes to 8.3% of the total population who have been diagnosed. with diabetes and another 79 million who are pre-diabetic. I said that wrong. The 8.3 aren't the 25.8 million aren't necessarily diagnosed. Some have been diagnosed, some are undiagnosed, but they're there. There's a really big concern in the U.S. about the rise of diabetes in children. So right now, 1 in every 400 children and adolescents are diabetic, and it is epidemiologically disproportionate among blacks and Hispanics. Asian Americans, by the way, are slightly higher than whites diagnosed with diabetes. Whites 7.1%, Asians 8.4%, and then Hispanics and African Americans much higher than that. So I also looked at the Singapore stats on diabetes and saw that it accounts for at least the statistics that I saw here, that it's number 2 in terms of the top 5, but they separated this out from cancer, so I don't quite know how that works. But it was number 2 in adult prevalence, and I was really surprised and alarmed to see, well, first of all, there is an increase in the population here. In 1998, it was at 9%, and in 2010 at 11.3%. So it's not good. It's a rising problem here. Diabetes is number 4 in accounting for polyclinic attendance, 8.9% of the visits to polyclinics. And diabetes, you may know, usually comes in a clump with associated problems, and those associated problems account for a whole lot more people in the population. And those problems include hypertension, high cholesterol, obesity, and smoking. And so for some unfortunate people, then diabetes is the end result of all those other things coming together. And as we'll see with Gina, there's also genetic predisposition. I also wanted to comment on her coming from Louisiana, because this is very meaningful for her and may not be familiar to people in this room. So Louisiana is one of the southernmost states in the U.S. It borders on the Gulf of Mexico. And it has one of the most interesting and distinctive cultures of all the states in the United States. So you may be most familiar with New Orleans, which is the largest city in Louisiana. Fortunately, Hurricane Katrina might be your association with that, but New Orleans is a very colorful city that people in better times like to travel to. She doesn't come from New Orleans, but anyhow, the culture of Louisiana is, there's a word to describe it. Yesterday, my husband and I were at the Brannigan Museum here and learned about the mix of cultures in this area of the world. So Louisiana, in some way, may be kind of analogous to that in terms of its mix. And the word that identifies that is Creole, which means mix, a mixture. So there were Native Americans to begin with. Louisiana, and particularly New Orleans, being on the Gulf, was one of the ports that imported many of the Africans who were brought over as slaves, and that heritage is still there. You can go to New Orleans and see places where they had the slave auctions. And a lot of African Americans have clustered in that area. So that heritage is there from Africa. For centuries, Louisiana was a Spanish kind of colony, and the Spanish ran that for many years. And if you go to New Orleans, you can see original tiles in the buildings that came from its Spanish heritage. And following the Spanish, then it went to the French. So I think a lot of people associate New Orleans with French, but the Spanish came first. So we have native, Africa, Spain, France, and then through this French connection, you're from Toronto, so you may know this better than me, but from French-speaking Canada, there were fur traders who did a trail from Canada down to Louisiana, and in Canada they came from an area called Acadia, and when they got to Louisiana they became Cajuns. And so there are distinct forms of music and dance that make up the culture, but particularly the food. People go to New Orleans for the food. And so this becomes a pretty important part of Gina's story. Both her mother and father are diabetics, as are her grandparents, her aunts, her uncles, her brother. This runs rampant throughout Gina's family. So within the family, and particularly with her and her brother, diabetes is known as the curse. It's the family curse. And actually, before age 24, Gina thought that she had come through this, that she'd be okay, and she had escaped the curse, and then she got this devastating diagnosis. And she's really kind of angry with her parents because of the genetic load. She says, you couldn't marry a non-diabetic, could you? You just had to double our chances of getting it. So with every, lifestyle aside, her genetic disposition isn't good. Oops, wrong way, sorry. And then she tells about what is going on with morbidity in her family. Her relatives have blindness, heart problems, amputations. All of this are the result of having diabetes. So again, in her words, on my mom's side, her mother and father had it. My grandmother was blind all her life and died of kidney failure as a result of diabetes. Half of mom's brothers and sisters, there are 9, have diabetes and related illnesses. Everyone on my dad's side, there are 7 kids, takes insulin and have had parts missing. My grandfather had no legs. My dad has no legs, and part of his chest is missing, and part of one hand is missing too. So this is the environment that Gina came out of. So for her, the traditional family plot, and so this is where our analysis went, is what's the plot of going on here, is that diabetes is there, it comes with severe losses and sickness, it's genetic, and therefore it's inevitable. And the way this is handled with Gina's family is, of course, it hampers everybody, but it's kind of accepted. Like, if you're in this family, this is what's going to happen. They don't seek a lot of medical help for it. There's one family doctor that people go to, who Gina doesn't think a lot of, by the way. People really don't seek alternatives or way of redressing this. It's like, this is what's going to happen to me. So when Gina gets this diagnosis at age 24, it's a major life rupture that inspires what I'm calling a ReEmplotting. And she decides, I'm going to do my life differently. I'm going to change my life story, because I don't want to go the way the rest of these folks are going. So she moves from Louisiana to Houston. So the scene of the plot changes, and she sees a bunch of doctors, but she seeks out specialty care for her diagnosis. No one in her family has ever done this before. So she seeks the help of a doctor who I'm going to call Dr. Winter, who is an endocrinologist, and diabetes is his thing to look after. She's the very first person in her family to have done that. And she's hoping for a better outcome. At my first visit with Dr. Winter, I wanted to see if he was going to be my doctor, and so I made my usual comments. My goal here is to be in the best health possible. I want you to put me in my grave with all my limbs. And if that means dying early by age 60, that's fine, just so I can have all my limbs. So for her, that was a major re-emplotment, that I am not going to go with my parts missing like everybody else in my family. In my mind, I was being an optimist. He, Dr. Winter, said, okay, I understand, but I don't think it has to be that way. The second time I saw Dr. Winter, I made up my mind that he is my doctor. So Dr. Winter sees a 34-year-old who's talking about dying at age 60, and her biggest goal is keeping all her limbs. And he's thinking she could get a lot more out of her life than that. But for her, that was a big re-emplotment. So the overall plot from Gina's perspective here is that she is determined to fight against diabetes rather than just to give into it as inevitable by seeking ways to change how she lives and deals with this illness. That's why she goes and finds a specialist. And then there's two subplots. One is her tension with her family regarding treatment because she's doing something nobody ever did before. And the second is her own internal struggle to gain control, particularly with her diet. She realizes, as most people diagnosed with diabetes do, that if she's going to do something about this, she's got to make a big change in her diet, and I just described the culture she comes from. And so it's difficult for everybody to make a change in their diet, but it's especially difficult here. I asked my aunt, is your cholesterol level still running over 400? Which, I don't know if you guys get your cholesterol done, but that's a huge number. She said the last time I went, it was 600. In fact, they're thinking of doing something because of stroke or whatever. I said, thinking about doing something? My doctor is having a cow because I'm at 325, and you're at 600 and something. I think they're supposed to be doing something. But again, this family is not very proactive. Another comment, when the doctor tells my family something, they accept it good as gold. You know, there's no questioning. I will question. Another part of her re-emplotment. So the struggle to control her diet. We're from Louisiana. In that area of the country, food and wine will probably be the top two vices for anybody. So getting diagnosed with diabetes was a big letdown for me because I love to cook and I also collect wines. I look at a list of things that they recommend that people should not eat in general and things that diabetics in particular shouldn't eat. I mean, everything, if you put those two lists together, everything on them is what we eat on a regular basis as a family. So she has a lot to change. Now, Gina and Dr. Winter getting together, their collaboration, part of that has to do with gaining the control that she's seeking. So Gina remarked to us repeatedly that Dr. Winter has the main control in their relationship, and she's okay with that for the time being. And that his judgment carries more weight for the time being than well, actually, his judgment over the other physicians, I think he'll always carry more weight with her. And she told us a story about where her gynecologist and Dr. Winter had two different opinions about something she should do. I don't even remember the issue. And they were kind of diametrically opposed, but unhesitatingly she went with Dr. Winter because that's where her trust is at. Usually I would say that I'm controlled by food and wine because I don't have the willpower. But now the control is with Dr. Winter because he has information on his side and has been giving me better medications that are treating both this bad habit, her dietary habit, and this bad disease. So she's collaborative, but she's happy to let him be the more empowered person at this point. Dr. Winter is my primary doctor because sooner or later everything gets back to him. Whatever doctor I go see is going to talk to him. But in spite of crediting Dr. Winter with power based on the information he has and the meds that he's prescribing, perhaps his greatest influence is helping Gina, from a narrative point of view, locate her narrative desire. This is a term that's used in narrative research. But in her case, that means the source of motivation for making the changes she needs to make in her diet and lifestyle. And she tells us this story. Dr. Winter recognized something in me. He said, "You're extremely competitive, so what I want you to do when you go walking," I have to walk from the parking garage all the way down to the building that I work in. He asked, "And how often do you do that?" I told him at least twice a day, going and coming. He said, "Well, try to make an exercise out of it." Now I find in the morning when I get out, I'm looking for that person who's walking fast, and I say, I'm going to try and beat this person, see if I can get there before that person does. So she makes an extra effort. And Dr. Winter was the one that saw the potential for doing that and for getting exercise she might not have gotten in her everyday coming and going. So, you know, in sum here, Gina has created a story on her own that's complete as a story in terms of having a complex plot, a broad set of characters with a clear hero, that's Dr. Winter, villains, the food and wine habits that she has that she can't control, not so innocent victims, her family, who kind of has let this happen, motives, scenes, and she's very oriented toward the future, and I'll come back to that. Dr. Winter, for his part in this collaboration, is helping her to again re-emplot her story. She re-emplotted it once. He's helping her to move that even to a different level. That is to help her answer the question of what story am I in, and particularly to help her imagine a new and a much better ending than dying at age 60. Out of Gina and the other stories that we looked at in depth, we came up with a model that I'll go through really quickly, but we were able to move from the level of the story to a more theoretical, abstracted level. And we plotted all our patients on this model, but I'm showing you what we did with Gina. So there are 4 continua that are part of this model. 2 of those are about attitudes that people have, 2 of those are more behavioral. And the first continuum, and this then is to answer the question of what is the meaning of an active patient, or what are the meanings, because there are a lot of meanings depending on the person. So the first continuum we called the centrality of illness. How central is an illness or health condition to the person? And I mean, the family, and I didn't talk to the family, so I'm extracting this out of Gina's story. Family has to be concerned somewhat with diabetes because their arms and legs are coming off at an alarming rate. But it's also just something that's there. It's not foregrounded, it's backgrounded, because it's just always there and people expect it. With Gina, it's central. It's the thing that drives everything in her life, and she says that. Diabetes affects everything I do. It's become a major part of my life. The second attitudinal continuum is changeability. How changeable does the person think their outcome could be? And with the family, they're at the end of where things are totally fatalism. Like, this is it, and we can't do anything to change it. With Gina, she's determined to change it, and she re-emplotted in order to be able to do that. She's still not quite at the end, though. She's got a way to go, but she believes in changeability. All I wanted to do was to try and correct it and to see if there was anything that we could reverse. I thought, I don't want to be like everyone else, meaning the people in her family. In terms of behavioral continua, engagement with illness has to do with the activities that people do to engage with their health condition and to achieve that changeability. And that goes from totally passive to fully engaged. And Gina is pretty engaged. She still has a ways to go because she can't quite control that diet yet, but she's working at it. Because it's my disease, I have it. I should be the one because I have the capabilities to monitor my disease. So she knows she has the potential and she's trying to act on it. And finally, patient-provider collaboration. Now, some people are very actively engaged, but they're not doing it in conjunction with their provider. So, in terms of being an active patient, you may or may not be collaborating with your healthcare person. But we put absolute patient control at one end, absolute provider control the other, and somewhere in the middle would be that kind of equal shared control. But Gina actually, you know, and right now she's closer to the provider control end. But I think she is aiming for more than shared control. She knows this is a chronic illness, this is her life, and she's going to have to manage it for the rest of her life. So she says, we'll work back and forth. I still ask questions. He still gives me information that he thinks is useful and will help me. But right now he has to prod me because I don't have control of the other end. And so that's what she is still looking for in her life plot. So that's kind of the theoretical part of this. I wanted to come back to Gina at the end of this, though, and just make a comment on what I think about her story, even though she says the doctor is really the person in control, at least at the point we did the interview. She's made quite a bit of progress, in my estimation, as an active patient. She's redefined her life goals in relationship to the diabetes. She moved to Houston, she got herself a doctor, she's chosen to prioritize Dr. Winter's advice above anybody else's. She asks questions, she monitors her health information, and she's made some progress in lifestyle changes. And she has faith that she can do even more. Because Dr. Winter and I work so closely together now, in the future, I think I will have more control over the diabetes, which is very important to me. In the future, I will be able to be a major player in fighting the diabetes. I'd like Dr. Winter to be more of a consultant than a controller. And that's where her plot, at least at the time of the interview, was headed. So I'm going to end here and see what questions and comments you have. Jeff?
I don't remember if you mentioned Gina's ethnicity, but I'm guessing she's white.
You know, this is really interesting. I don't know Gina's ethnicity.
Okay.
Paul does, but I don't. Yeah.
And the reason I ask that is because you labeled her as a 34-year-old person from Louisiana with diabetes. And I'm wondering how Gina would label herself. Because if it's important, what story am I in? You would think also, who am I in this story? And the way that you label yourself, it would tell you what's important to them. So I wonder if she would say, I'm a 34-year-old white woman, Christian with kids, or Jewish, or what, you know,
Good.
right?
Good
And
point,
so I was just wondering.
Yeah, that would have been a great interview question.
Yeah. So you don't
One
know.
of Kleinman's questions, but that would have been a great interview question.
Yeah.
I agree. Yeah.
Yeah, it's really interesting stuff. There's a couple of things about it that trouble me a bit. One is you haven't made a strong distinction between type 1 and type 2 diabetes, and that I think that's maybe spins it in a slightly odd way, because type 1 is a genetic disease. Basically, your body doesn't create insulin. If you don't treat it, you're going to die, and you're going to die horribly.
Right.
It doesn't matter what you do, you know, it just has to be treated. So that's clearly what Gina's got. And the stuff about her lifestyle helps, but, you know, it's the treatment that's really, really important. And that puts
Yeah,
and I think that puts your sort of good guy, bad guy narrative is a bit odd in that respect, because it's
who's the bad guy?
so the family, you know, who don't.
I didn't label the family as
All right.
bad.
But she does, yeah, and it's an interesting moral narrative that's in there. And
I think she labels her diet that's out of control as the bad guy. Her family, I think it bothers her that they don't do more, and that they genetically gave her this, but I don't think she'd say they were bad guys. But, I mean, you're right, but she didn't bring up the type 1, type 2, and she mentions medication, she never says insulin. So, it's her story and it's her words.
Yeah, it's just I guess it's just an interesting morality in there that might worth pulling out a bit more. That, you know, because to me it is a legitimate position to be passive if you want to be. You know, I mean, there's nothing wrong with that. You know, you don't have to fight your illness if you don't want to. It's your life. Live it how you want to. And that,
Which, you know, yeah, I'm not passing judgment on her family, but I think she does, because she's the kid for whom they were all the examples. And so, yeah, she's made the choice to deviate from the family.
Is your point that there are certain villains available that plausibly fits into the story, depending on if it's genetic, type 1, or simply adult onset? Right? I mean,
to some extent, yeah. I think you've got. I mean, the whole good patient, bad patient dialogue is I think a modern creation. You know, I don't like it very much, if I'm honest. You know, I think at the end of the day, it's the doctor's job to treat me, and it's my job to live my life. And I'm not sure that dialogue is an entirely healthy one, no pun intended. But yeah, I think that the genetics creates an oddity within this story, because if you confuse, type 2 is a bit lifestyle related, and you know, it is associated with overeating, overweightness, and so on and so forth. Whereas type 1, I mean, at the end of the day, it's like you can't control it with lifestyle changes. You just can't. It's not that kind of disease.
We're going to see something during the workshop. We're going to see another patient narrative with another patient with diabetes, in which insulin control is a central part of the story. But Gina never labels it as such. But she does label the food.
That raises an interesting question for me, because I'm not very familiar with the way you do this sort of analysis, but it sounds like what you're doing is really entirely basing your analysis on what the participant has said. Is that the case? I mean, he was raising questions about what sort of diabetes, and it sounded like you actually didn't sort of look at external data about the patient.
We did not.
Is that, I mean, I'm wondering.
We were using their stories.
So it's really about the story they tell and the contextualization or anything. I mean, you have some, you say, things about being from Louisiana. I assume that she told you that, or did you find that outside of the
I
narrative?
live in Texas, I live next to Louisiana,
Yeah.
I know that.
So where do you draw the line in terms of what you just take
I
strictly from
mean,
the narrative?
I'll just answer as a narrative
Sure.
scholar with this. I think contextualization is important, like the context in which the story takes place. So I know something about Houston and the medical system there, I know
Yeah.
something about Louisiana. But in terms of looking up her medical history, and I guess she wasn't Paul's patient, but if anybody was going to do that, it would have been Paul. I don't have access to that. But no, he wasn't checking her against the medical record.
Well, I wasn't thinking so
That
much
wasn't
checking
part
that.
of the context. We never even thought of doing that.
I wasn't thinking so much about checking, but bringing in sort of more background to your analysis. But it sounds like the focus is really how does she tell her story? That's what you're
The
interested in.
focus was, what does it mean to be an active
Mm.
patient?
From her perspective and the way she talks about it. Okay. Thanks.
So I was struck by your comments about how doctors actually label some patients as being poor historians. But I was just wondering if there's been a shift in that over time, especially with the use of the internet, because when you go onto the forums where people discuss medical problems, they're very good storytellers. They're very good historians. You know, they say I've had this condition for so long, and so on and so forth. And I think it's got to do with the internet being a textual medium, and so people also not having the contextual history of individual patients, and so everyone's being very open about their histories. But as a result of the use of these kinds of forums, does it sort of change the way patients are able to recount their personal histories to their healthcare providers?
I think that's a good question, and I don't have the answer to it. I have also studied online forums. I did that with women with breast cancer. But I think they're not telling stories. When I say doctors say they're poor historians, it means that they're not, they may be very good storytellers, but it's not in the format that the medical people want to hear. So if the doctor's question is, can you tell me when this complaint started? And I have videotapes with this kind of thing. So the patient says, well, back when I served in the Army 17 years ago, this and this happened to me, and I had these wounds, and I've been having trouble with this ever since. The doctor isn't wanting to, and that is maybe said to be a fault with the doctor, but the doctor isn't wanting to, they want to know when this particular episode that brought you into the office started. And a lot of them will think, I have to listen to this whole history from 17 years back. Now that may be very pertinent history. I'm not saying the patient is a poor historian, but in terms of what the medical people are wanting to hear, it doesn't fit their formula. And that's where that term poor historian comes from. It's like, I want to get to what's happening now, and I only have so much time to do it. So the way people introduce themselves on the internet, at least the forum that I looked at, they're not talking to doctors, although doctors might be on the, or nurses or whoever might be on the forum, but they're talking usually to other people that have a shared condition. It's that creating community function of stories that is happening on those illness forums. And so those stories serve a different purpose for a different audience. Okay.
You know, Gina's story was so interesting, Barbara, in one way, thinking about this question of value. In a sense, the value, it seems, emerges from within her story, as she narrativizes it. And perhaps, you know, when I think about Rita Sharon's work on narrative sense-making, perhaps that kind of a value frame has a role to play in her making sense of her life and the life course she's going to pursue. Yes.
And you know, to this question about being a poor historian, I mean, my understanding is we're teaching doctors in patient-provider situations how to be a better listener, right? So we have this you know, when did this start? and the person says, oh, well, it was, no, I was on vacation 2 months ago in Cuba, and you know, if the doctor's listening, right, they can go, oh, Cuba, you were in Cuba, there's been an outbreak of, right? And so letting the person sort of narrate the context of what, of how this is defined, I mean, doctors can miss out on all that pertinent information.
Absolutely, especially if they're cutting in 18 seconds into your
Right, and that's
first
7
thing you're
minutes,
going to
right?
say. But we're going to, during the workshop, read a piece that Paul wrote with a colleague, Deborah Paternalism, and it's called I may not have the title right, but it's something like history building versus history taking, because what the medical personnel are taught is taking a history. And if you think about that metaphor, it's like kind of swooping down on the patient, whoop, there's your history, I'll carry it away. And again, puts the patient in a fairly passive stance. Whereas if you're collaboratively building a history, again, it takes both doctorly knowledge and self-knowledge to build that history and have it make sense and be useful. So just the language and the metaphors that sometimes fly around in the medical world are kind of destructive. Labeling somebody as a poor historian or a history-taking, or another one that really gets me is, I may not get it right, that it's something that, I'm afraid I'm not going to get it right, but the patient failed a particular test, a medical test, but it's like, the way it's phrased, it's like the patient's fault that this didn't work because they failed it.
Should have studied more.
Hmm.
And so just the language that is used is, to my mind, counterproductive.
Yeah, the patient
sometimes.
presents with, no, the patient has.
Yeah.
I may be jumping ahead a little bit to something you would talk about in the workshop, but I'm curious to know, kind of merging your interviewing and having the time to really sit down and analyze an interview versus a time where a physician or a healthcare provider is sitting down with a patient in a very limited amount of time they get to spend with the patient. Where is the intersection of how narratives can be useful in history building or history taking when they're so constrained to this, 10 minutes or 5 minutes even? Is it something that as communication scholars we study, find patterns, and then make suggestions to how to train physicians, or is it something that you think is more suited to those 5-minute interactions? Or
Well, I do think it's different, having the luxury, if you will, to be a scholar and to spend all this time looking. It's usually, in the US, the average time is not 5 or 10 minutes, even though it might seem like you're being rushed through that. I don't know about the Singaporean context. It's usually between 15 and 18 minutes, so there is more time, and this is a topic that's been going on for a long time, ever since that kind of landmark study that Frankel and Beckman did about the 18-second interruption, which is, the doctors think that they're being efficient by breaking in 18 seconds after the patient starts to open their mouth. But not letting them finish that statement of concern. Yes, it might have taken a whole minute or 2 minutes for the patient to finish that concern, but that might have reoriented the whole conversation. So it's a little bit of a straw man to say, oh, but doctors are so rushed. They are rushed, but they also get to see patients over time. Not everything gets accomplished in one conversation, but that's partly why we keep chart notes, is that they are building a history, and not just in one conversation, but over time. So part of the challenge for people that are training doctors, and I'm not doing that anymore, but is to show them that efficiency can work in other ways, like by hearing the whole story and going from there rather than missing that key piece of information that they were in Cuba 2 months ago. But with, one of the sites for this, as I said, was the Veterans Hospital, and a lot of the veterans, especially the older guys, they do take things back 20, 25 years to when they fought in such and such war, or this kind of conflict. And maybe something really, life rupturing did happen at that time that has affected their whole pattern since then. And a lot of the doctors don't, I think they have blinders in terms of how far we go back to really track the evolution of it.
I just have a question. Out of curiosity, does age of the healthcare provider have anything to do with it? Because I went to a government hospital here, and this is during my pregnancy, and my gynecologist is this younger Singaporean Chinese man. And I always go with my questions and take out my notebook, and he answers them very sort of patiently and goes through them with me. And then I went to an endocrinologist who was a much older gentleman, same Singaporean Chinese, and it was less than the 18-second rule. So I started to say something like, stop. I was like, oh, okay. So I think, is there sort of an attitude amongst the older generation that they don't really want to hear your story as much?
Yeah, so we've been trying in the US anyhow to teach communication skills in medical schools, and nursing schools do it as well. I think the other health professions may not be quite as much into it, but we've been trying to teach communication skills since the late 70s, early 80s. So I do think there is a generational difference in terms of the doctor's training. It also may have to do with their specialty. But I think the younger doctors have at least been exposed to more of that, yeah. That's good to know it's made an impact. Yeah.
I'd like to know, how do you differentiate between an overall plot and a subplot? I mean, when you're confronted with a transcript, for example, how do you decide which goes into the overall plot, and how do you pick out a subplot?
Answer this exactly. I mean, it's a judgment call, but the overall plot with Gina was, in her own words, the struggle of finding control. That seemed pretty evident and pretty easy. But when you looked at the surface, there seemed to be some separate parts of that struggle. And one was with her own family, and she keeps coming back to the family and how she's trying to break with the way they've handled things before. So that just seemed like a specific part of the struggle. And then she out and out says, I can't control my diet, but I know I have to. So that she clearly states that part of the struggle. So it's interpretive research. It is an interpretation. Somebody could interpret it differently.
So Barbara, how might Gina's story look differently if she were to co-construct the same story with her family, and do a narrative employment in that way together, and then if we were to talk to Dr. Vinna? So is there any work that sort of explores this idea of narrative outside of the patient to other contexts in how the story is put together?
Not this story. I mean, we didn't have access to her family life, but other people have done that. So one of the people who I think does good work in if I'm understanding you, tell me if I'm understanding you right, but Wayne Beach at San Diego State, who is more of a discourse analyst, he does much more microscopic, linguistically based work than I do, but he's looking at, and he's actually, I'll tell you what he did in a second, but he's done a whole body of research around, his data is recorded phone conversations after a member of the family, and in this case it was a mother of a family, gets cancer, and how the family members are talking about it. And it's really interesting work, and he's been working at kind of with the same body of data for a long time. He's gotten a big federal grant out of it, for one thing. But one of the things that he's done is he's written a play using the dialogue from the data. And we're going to see some performance-based stuff in the workshop based on somebody else's dissertation data. And he's using that play, it's being produced, I know, around San Diego. I'm not sure if it's been put on anywhere else, but they're gathering data from the audience about their reaction to the family's conversation based on the play performances right now. And I'm not sure what he's going to do with all that data. But is that an example
Yes,
of what
yes.
you're asking about?
Yes.
Yeah. Or I think if you would look at least this was true with the forum, the breast cancer forum that I looked at how people writing into a forum with other people with the same medical problem, they bring in all kinds of things about their lives, about their family, how to discuss this with their kids, how to go on dates if you've had a mastectomy, I mean, all kinds of things.